recent years, but a commentary piece in the Medical Journal of Australia argues that the power of placebos is overblown. One of the authors of the piece is Professor Chris Marr from the University of Sydney, who joins us now. Hi, Chris.
Hello.
So your commentary is arguing against placebos in clinical care, but they have been associated with good outcomes in the past, haven't they? Like, why shouldn't they be considered as part of the mix?
I think the argument is that people are overstating the case for placebos. When we've studied the size of the treatment effect, they're not powerful as advocates are suggesting. And the other thing is, probably of the dozen health conditions that have been studied for, it's only really 2 conditions where there's any evidence that they have some small effect. So portraying them as some sort of powerful panacea is, I think, overstating the case.
How much is it actually happening that doctors are out there prescribing placebos on purpose?
Well, if you look in terms of the major medical journals, there's been commentaries in the BMJ and also the New England Journal of Medicine. A survey of Australian GPs found that 40% of GPs have prescribed a placebo in their career.
40%, that's huge. So the conditions, you mentioned a handful of conditions. There are things like pain, nausea, irritable bowel syndrome, lower back pain specifically, depression, obesity, things that are complex often. Is that why maybe they are being prescribed in those areas?
I think the reason they're being prescribed is because people are reading some of these overhyped, poorly conducted studies and believing them. And so really we need to be a little bit more savvy when we're reading research articles. And I guess journals have a responsibility to guard that some of the information that's being presented is actually accurate. The other thing I'd say is that some of the conditions you mentioned, we know that placebos don't work for. So things such as smoking cessation, dementia, depression, obesity, hypertension. In the Cochrane review, those were the conditions where placebos didn't have an effect.
Are these conditions where there are treatments though? If there's no treatment, maybe there is an argument to prescribe something that might have an effect.
Yeah, I guess I'd take you back a step, because for most of the conditions where the placebos are being used, there are real treatments which work better. So if you look at most clinical trials and you're comparing an active treatment to a placebo, for most health conditions there's an active treatment that works better. And I think really in terms of the role of the clinician, it's to help the patient decide between active treatments rather than offer them a placebo treatment. And I guess if there was some new health condition where we have absolutely no treatments, then I guess maybe you could consider using a placebo, but it would be on fairly uncertain grounds, and there are some ethical issues in doing that.
Yeah, can we talk a bit about the ethics of it? Because you've either got, you think the effect is that people think that it's going to work and they're being misled, but you mentioned in your article that there's even suggestions that people get some sort of placebo effect even when they know they're not getting an active treatment.
Yeah, so that's a more modern version of placebo. They talk about open placebos where they actually disclose to the patient that they're getting a placebo. The thing about those studies is they've got a lot of flaws to them. So the one that most springs to mind is one that suggested that if you took an open label placebo, you told the patients it was a placebo, they took it for 3 weeks for chronic back pain, that it had long-term effects for 5 years. But when you look at the study, they actually threw away the control group. And so it was no longer a trial. And I guess you'd have to wonder, why did they throw away the comparison group? And perhaps if they had the comparison group and the placebo group, you wouldn't have seen that benefit at 5 years. It's a funny way to do a study.
What are patients' attitudes? I think there's a pretty clear argument that doctors shouldn't be prescribing things that don't have a clear effect. But do patients ask for these sorts of things?
I'm not sure if patients do ask for them, but I guess the best answer for that would be that you can actually buy on the internet open-label placebo pills, and there's a couple of different brands of them. So presumably if there's a product out there. So this is for people to self-medicate with their own placebo. There's a couple of different brands. There's also a form for children, which is a chewable form, and they're actually quite expensive. So the one you can get from the Australian website is $150 for about 45 capsules, which is quite a lot of money, $3 a capsule for, I guess, something that hasn't got much in it.
What about we've mentioned another phenomenon on this show before, the nocebo effect, where people are expecting a bad outcome. What are your thoughts on that?
I suspect if you go and look at the science carefully, you'll find much the same as for placebo. It's really hard to believe that you can have, powerful nocebo effects and powerful placebo effects. When we've gone looking for placebo, they turn out to be at best modest, and I think the same thing would be the same case would apply for nocebo effects if you look carefully. I think for both of those things, we've overstated the benefits and we've probably overstated the harms.
Well, just briefly then, what are the harms, if we're talking about a treatment that's inert, what are the harms of prescribing this as opposed to the treatment itself?
I think it's really the opportunity cost. If people are being given placebos, they miss out on the opportunity of receiving a real treatment. And I guess the other thing that concerns me a little bit is people being encouraged to self-medicate with open-label placebos that they buy on the internet. I'd much prefer that we have people seeing a clinician to get some advice about a health condition. And I'd much prefer we have a situation where the clinician and the patient are choosing between active treatments rather than pretend treatments.
Thanks so much, Chris, for joining us.
Thank you.
Christopher Marr is a professor in the Sydney School of Public Health and director of the Institute for Musculoskeletal Health at the University of Sydney.
I just love all that placebo stuff. It's just so fascinating. I've done many stories on it over the years. It is about expectation. It's what you're led to believe. And I just can't help thinking, is it a bit more powerful? Research done in his area, in Chris's area, in musculoskeletal disease, which was done by Rochelle Buchbinder in Melbourne, looked at arthroscopy and placebo, and the placebo effect in arthroscopy was actually pretty powerful. And there's a fascinating study about acupuncture, which is where
with the retractable needles.
Well, I don't know about that study. Tell me about that study, and then I'll tell you about mine. You tell me yours, and I'll throw you mine.
Now I'm realizing that I don't know the thing. That I've got this memory of something with retractable needles where they basically used sleight of hand and they used like close-up magic to make people believe that they were being acupunctured, but they weren't. Yeah,
well, I don't know what the results were in that study. With complementary medicine, unfortunately, the bigger the studies and the more and better designed, the less likely they are to actually show an effect, which goes along with what Chris is saying, because you minimise the placebo effect with a large, well-designed study. But this study is actually of acupuncture, where people got needles, and they got needles according to the meridians, according to classic Chinese medicine, and then they got needles in random areas of their body, and both got an effect. So that's probably not the placebo effect, but what it is the effect of the needle in the skin. So in other words, simulating that. So what probably is a placebo is the whole shtick about the meridians, if that story's true, whereas sticking a needle in somebody does actually help your pain a bit.
But as you say, with things like pain and those sorts of complex things, the answer is often not just a single pill that you can take. So it's really hard to extract the mental side of things or the psychological side of things from the treatment itself.
Yeah, and there was a whole area around statins where if you were told you to expect muscle pain with statins, cholesterol-lowering drugs, you got muscle pain. And so the nocebo effect was considered quite strong with statins. Anyway, interesting topic, which is taking us away from our mailbag.
Well, that's right. And the mailbag is chockers this week. We're going to have a mailbag free week again next week. So we're going to get through a few today. And there's quite a few people who've written in about Sarah Sedgie's report last week about borderline personality disorder.
And if you haven't heard it, you must get it. You must download the podcast. It was a fantastic program with a huge response.
It was massive, and Barbara was one of the people that wrote in saying talking about underdiagnosed and stigmatised illnesses is so important. The medical system and those who are a part of it really need to up their game. Most people, and Barbara knows, with chronic illness, mental and physical, usually need to do their own research and advocate for themselves to get anywhere with diagnosis and treatment. Well, that's actually a theme we're going to pick up on next week on the gender gap in healthcare.
Yes, it is a general problem where you are thrust on your own devices to look after yourself, and if you are not well equipped to do that, are well resourced, or have time in your life, or if you're a grandparent with 3 grandkids with a single parent that you're helping to look after the grandkids, it really does become a problem. And also knowing where to get reliable information, apart from, of course, the health board.
Well, of course. And Kim has also written in saying, if dialectical behaviour therapy programs and DBT-trained psychologists were more widely available, many people would be able to get the help they need. Thank you for this episode shedding light on borderline personality disorder, trying to take away the stigma that surrounds it. People with BPD are very misunderstood, and I get why they don't disclose their condition. People are afraid of what they don't understand.
And those are only just 2 examples of the many comments that have come in about that program.